Payment Matters, where we discuss all things healthcare payments. I'm your host, Jeff Lin. Thanks for listening in today. You can follow the show on Twitter at #PaymentMatters, and follow me at Jeff B. Lin. For today's episode, we're going to be talking about payment assurance. How can healthcare providers ensure they get paid from patients? I'm joined by Joe Clark, CEO of Sierra Pacific Orthopedics. He's going to share his experiences changing the way his organization engages and collects from patients by implementing both a technology solution and really key change management components with his own staff. Thank you so much for joining me today, Joe. As a first step here, first question, can you tell us a little bit about Sierra Pacific Orthopedics, what you guys do, how you guys do it, and a little bit about your practice?
Sure. Yeah, thanks, Jeff. I have been with the practice since inception. Basically, we opened in 2002, and I came on back in 2001 to help build our facilities and recruit physicians to the practice. We opened doors in 2002 with 10 physicians and quickly grew to 15 or more physicians within 5 years. Currently, after 17 or 16 years, we're at 23 physicians and 20 mid-level providers, not including physical therapists, and we have about 10 physical therapists as well. But our goal was to create a comprehensive musculoskeletal practice where you could come in with your issues and have them all resolved here. So physical therapy, MRI, radiology, all in one location. We quickly outgrew some space and added a second building for physical therapy. So we have about 85,000 square feet where we are currently, and we're just opening in the next 2 weeks our second building, which is close but around the corner to us, another 38,000 square feet. We're going to move all our spine physicians there and have a dedicated spine center. We'll still be doing surgery at our surgery center that we have in this current building, plus an inpatient hospital that we have also in Fresno. So that part doesn't change, but we're going to free up some space in this building by moving our spine docs to a new building. So it's been a pretty quick ramp up. I mean, we got to, I think, 20 physicians, 19 physicians very quickly within 10 years or so, and then we've kind of just bounced around, and the building got full, and now with the added expansion, we're able to move ahead and expand some more. So we've seen a nice increase in volume and number of physicians and practice, and so yeah, it's been an exciting run.
It sounds like a great run and phenomenal growth. So maybe when I hear the word Sierra and Pacific, I think of a beachfront location in the mountains. So can you talk about where you're located and also the type of patients that you see, if you were to categorize sort of the target segment that you guys focus on?
Sure. We're centrally located in Fresno, California, so we're right in the heart of the Central Valley. We're 3 hours from San Francisco. We're 3.5 hours from LA. We're a couple hours from the Central Coast, and we're within an hour to an hour and a half of about 3 national parks. So we're actually closer to those Sierra Mountains than we are the Sierra Nevada range than we are the Pacific Ocean. But we do have patients that we reach from there, and we do see patients as far south as Bakersfield. We see patients as far north as Modesto, and then some Central Coast that come over as well. So that's the idea is, orthopedic surgeons typically are outdoorsy by nature, and so they're very involved with outdoor activities, mountain and ocean, and many of them work here and play at either the ocean or in the mountains. So that was the name. The patients we see is, I think, probably kind of a normal practice. I think we don't see a lot of Medicaid just because we don't have the capacity to do it. We see a nice 20 to 25% Medicare population, about 15% workers' comp, and then really the balance is probably commercial payers, some HMO business. There's not a lot of HMO business here, but there is some. And so it's really a nice private practice for these physicians. So quite a bit of commercial business.
Great. So pretty interesting space being in Central California. So there's been a lot of talk across the entire industry tied to really the challenges in collecting from the patient, and that's it's varied in nature in terms of the people, process, and technology. I know you guys have implemented a lot of changes to support enhanced payments, but maybe before maybe take us back a little bit, a few years or a couple of years. Where were the challenges you saw from a patient payments perspective? And then we can quickly kind of go into what you've done to address those.
Sure. When we opened the practice in 2002, we were faced with patient responsibilities that probably made up, I'd say 10 to 15% of what we were paid on a patient visit or a surgery. 10 to 15% was a patient responsibility. That number today is, probably pushing 40%, in the 30 to 40% range. So where before it was 10 to 15%, reimbursements were, I wouldn't say reimbursements have gone up or down. I think we've had kind of a flat reimbursement in total. It's just the percentage that has shifted from the insurer to the patient has significantly increased. And so a few years back with the Affordable Care Act, we began to see, we were seeing some high deductible plans in the range of $750 to $1,000 to $1,500 deductibles. But now, with the Affordable Care Act that was 3 or 4 years back, maybe 4 years back, we're seeing plans that have deductibles of $5,000, anywhere from $3,000 to $5,000, which is really a game changer for a practice, because where we're used to just having the patient come in, we scan the insurance card, we see the patient, we collect their copay, and then they see the doctor and they go on their way. Well, now, if you do that at the beginning of a year, the likelihood of you getting paid is significantly reduced, because many of those people that have qualified for the $3,000 or $5,000 deductible plans on the exchange are not able to maybe meet their demands or meet their deductible. And so if you have no security or any way to collect from a patient, a lot of times it just went away. And so we went back through and started doing an analysis of what we were writing off in patient responsibility. It was significant. Over a 3-year period, it was in the millions. So we began looking for a solution to that. One of the challenges with orthopedics, and probably some other specialties, but not as many as I think orthopedics. When a patient comes in, we really don't know what we're going to do, because we have the ability to do the x-ray here, do the MRI here, dispense a brace here. Maybe they have therapy here. We really don't know what level we're going to code, whether we're going to code a level 2, 3, or 4, or 1, or whatever we're going to code for the patient. That's all different reimbursement, and it's all different amounts of copays for the patient depending on what happens there. So it became overly complex to try to predict what the reimbursement was going to be. Therefore, what would the patient's responsibility be if their part was 20% of the allowable plus their copay? We knew we could get the copay, usually set it on the back of the card, but the other part is that coinsurance that they pay. That's based on expected reimbursement from the payer. So the challenge was, how do we collect that, and how do we accurately calculate that on the front end? We have not been able to get to a point where we can calculate as soon as the patient walks in, especially seeing 400 to 600 patients a day, what they're going to owe when they step to that window to check in. So the solution for us, both for us and for the patient, really was to maintain a patient's credit card on file, allow the insurances to be billed, not take money from the patient in advance of the visit, let things sift through the insurance, and then come back with an amount that the insurance says they're actually going to owe. At that point, we can notify the patient the amount that we're going to charge the card, and we're able to do that. The advantage for the patient is that we're not taking an advance payment. Therefore, the patient doesn't have to worry about trying to get a refund if we took too much, coming up with more if we took too little, if our estimate was off. A whole host of other possibilities with insurance contracts and whether you can take advance payment under our various contracts, whether you can take deposits like that, things like that. So we're always sifting through those legalities as well. This is one that was perfectly legal because we really weren't collecting from the patient until after it was all said and done, and after the insurance had adjudicated the claim and it's coming back to us and saying this is the amount they owe. So give them the proper notification and charge their card, and it really, thought that would be the best solution for us today. I may have jumped ahead a little bit on you, but
yeah.
I think that the key drivers was really the amount we were writing off from patients and really not having a great way to collect the amount when patients come in the door. Now we're not in we're not in one of the top affluent areas of California. We live in the most affluent probably part of, we work in the most affluent part of Fresno possibly, but it's not like it's we're not sitting in Orange County. So it definitely poses us challenges getting paid that coinsurance, and it was starting to eat away at the bottom line. If you were, like I said, if it was 15% one day, and then now you're looking at 30 or 40%. If your overhead for a practice, I'll just shoot at an average 50%. If your overhead for a practice is 50%, and you're losing 30% of your money, you just took the profitability of practice down quite a bit by not being able to collect that patient portion, along with the chase that has to happen to the patients. You're always making an effort to collect if you don't have any security interest. So the way I like to kind of phrase this is what happened over time was we became kind of the creditor with no security interest. So basically patients come in and walk away, and it's like we just gave them a loan with no collateral. And you'd never see a bank do that. You really don't see any other business do that, and we've been slow to get that ball rolling in healthcare for some reason. And I just looked at an article this morning that how much hospitals are writing off. So I kind of began talking about this topic about 3 or 4 years ago, and I'd go into a room and there'd been nobody implement this. And now as time has gone on, there'll be 2 or 3 that have actually implemented this process as well. We have 2 other large practices in Fresno that have actually done the same thing, but I think it's I don't know any other way to do it at this point. In today's, the way we bill our services today, the way we have to code and the way we reimburse, the way we are reimbursed from insurances, I don't see another way of doing it rather than this.
Yeah, it's a great story here because I hear and it's highlighted here the chase and the real financial penalties and the write-off associated with the scope of patient responsibility, and the fact that it's 30 to 40% of your overall revenue, right, for Sierra Pacific Orthopedics. One thing, maybe if you can highlight this, which is the patient experience, and how did you manage through that? Were there patients that walked in that didn't want to save their credit card on file, how did you manage the change aspects for a patient and even probably your staff associated with this shift in leveraging new technology to, create that payment assurance that you'll get paid after the claim adjudicates with the payer?
Well, I think that it's probably important to understand two pieces of that. One, we really emphasize, staff training, probably the most critical component of what we've done with that. The other piece is really just kind of helping the patient understand it's really to their benefit, but you still have a fraction of patients that they don't see it that way. They have they're nervous about their credit information being stored, so you try to explain to them the security that we have in our payment vendor, but we also want to always have options. So options are the key, we think. If we just said credit card and that was it, we're done, a patient might not have a credit card, or the patient might have maxed a credit card, so you could be limited. So we always offer something else for those that are just so uncomfortable with it that it doesn't work. So we do offer a deposit situation where they can actually write a check or advance money early at the first visit, and then we either refund or bill further after the insurance collects. That's one way, but then they have to do that every time they come in. So when you give that option, we also have a couple of credit choices as well through banks where they can actually apply for a healthcare kind of credit card through a bank and use that. So it's another option. So we have maybe three options that are available for the patient. And so that's the first piece is like, hey, okay, it's not a no if you can't do this, but here's the other options. So we work through those options. With regard to training staff, I think number one, I think staff generally did not have a good feeling of where the industry had gone. They don't really see what we get paid. They don't really see how we get paid. They don't really see the amount we get from the insurance versus the patient. They don't really know that number. And so I think educating them on some generalities, some general fundamental healthcare reimbursement concepts, making them familiar with how we're paid and why we're moving in this direction. When they start to see, the numbers and the shift from insurance responsibility to patient responsibility, then they start to understand. And now you start developing some buy-in with staff. And I think if you don't explain why we're doing it, you just look like you're just hungry for money. And we're not taking care of the patient, we're just trying to get money. And that's not the case. We're trying to get paid a large portion of what we're reimbursed when we think we're reimbursed too little already in a market where you might be getting less and less every year from a commercial payer. So now if they have that understanding, they can see, okay, this is just as important as getting the patient's insurance card, and the proper information to actually bill the insurance it's equally as important. And so you develop that kind of skill set and mindset in the employee, and then you go through training scenarios with them. So we would educate them on what the industry had done from 2002 to now. We actually had meetings with them in groups so they could ask questions and they can talk. And here's where we're going, and here's what's happened, and here's the amount we've written off over the last couple of years. And I think being a little bit more transparent with staff is important when it comes to really implementing a new process like this. So we do that, and then we go through trainings on what questions the patients might encounter or give you, and what you might encounter from the patients. And so we have some frequently asked questions that we can give to patients, and we actually send that in our new patient package a lot of times. We will also go through a scripting methodology. So they have actually scripting what they say when they're talking to patients about the credit card, because they can get off track pretty easily. So this brings them back on track. And I don't want to go into a bunch of examples about how they would get off track, but when they start freewheeling is generally when it's difficult to convey to the patient the message you're really trying to convey. And so when they stayed on the script, it sounded like we were in a better position to move forward with the patient's credit card, making them comfortable with giving their card, et cetera. We actually try to get the card at the time of making an appointment on the phone. If they're in their car, we have them bring it in, or they call back, or another way. But we do attempt to get that information on the card and actually key it into the system live, when they're making the appointment. We think there's no better time to do it than that, because it actually avoids anything in the office when they come in. We already got it. It's no big deal. If we wait and we don't get it at the appointment, now you've got this that the front desk person has to do. Instead of just checking in the patient, seeing the patient, getting them treated, checking them out, moving on, now you got to deal with this issue. So it's best for us to get it at the time of making the appointment. Doesn't always happen, but that's the goal.
That's those are great insights. Because we hear a lot of companies that it's only technology, right? And we clearly know it's the process, the scripts, the training of the people to make sure that it's well adopted. You had launched this program and tied to saving and driving payments with your patients and saving their credit card on file. What kind of results have you seen from either a consumer adoption perspective, but even any financial benefit that you've seen after implementing this type of program?
On the adoption piece, I still think you're always going to have some folks that are a little uncomfortable with it because it's handing your credit card over. But here's a situation where you're giving it to your medical provider. Okay, this is not like you're handing it to a waitress or a waiter at a restaurant, and he's taking it back with him behind the counter where it's just he and his the card. We're not walking away with the card like happens every day in a restaurant. They run a greater risk of your card being stolen in those situations. So it's actually quite secure, and we just try to convey that to them. Patients, I think, have responded well in age groups. So we had several scenarios that we had to deal with. Existing patients on the specialty side, it was when I say specialty side, like the orthopedic surgery side, it was new, but it was okay. If they were coming in for a new condition, or if it was a new patient in total, we had no issues with getting the card. If the patient, we don't do this on Medicare, so it's not our more senior patients. It's our younger patient, and they've responded very, very well. I've had maybe one person over the last several years that has made their way to administration, or maybe two, to just talk about the program. But in general, we had no issues the day we turned it on, the day we started doing it. From new patients. Now, from existing patients, you have a little bit more work, because you got to explain why the change, because it's a change. For new patients, it's not a change. It's how they do things. So for existing patients, a little more education. We have family practice here too, and so some of those family practice patients have been here for years and years, 20. They've been with these doctors for maybe 20 plus years. So that was even more significant change, and we just have to do some advanced notification. We had to explain to them a little bit more. We had to work with them a little bit more. We had to talk them through it a little bit more. But I think in the end, it's got us to where we wanted to be. So that your first question was how have patients responded? So I think they've responded well. It's anything new like that is going to be an adjustment, but I think just having that proper education is important.
Has it gotten easier over the years since the inception when you launched this program?
It's gotten easier, but we have to maintain our training. So it's just like anything. If you're a baseball player and you're hitting well, and you decide you don't need to start doing batting practice, then pretty soon you're not going to be hitting well. So if you're an infielder and you're fielding ground balls, if you don't take 100 of those a day, chances are you're probably not going to do it come game time. So we did a lot of role playing with staff, and so role playing is important, and ongoing training is important. So it's not easy. It's not that you can just turn this on and leave it. You have to nurture it a little bit, and you have to keep going back to the training, and you have to keep bringing them back to where and why you did it, and then talk about the scripting and reminding of the scripting. Plus, you have some staff turnover, so you're always training new people on how to do it as well. So it's like any initiative in either a hospital or a medical practice. It's great when everybody's talking about it and it's charged out and we're doing great. And then if you're not measuring it, it tends to wane off. Like you'll see a decrease in the amount of cards. It shouldn't even be allowed to do that, but you do see that. You see a decrease, and so you got to bring it back to their attention. So what happens is now we have constant measurement of number of patients that we need renewal cards on because their cards are expiring. So we work on this weekly now, and so we look at how many when we don't have the card on file, why don't we have it, and then let's get it when they come in. So we have edits built in. When the patient checks in, the edit pops up and says we need a new card, we need a updated card, or we need a card on file because we don't have one yet. So it's a lot of that kind of all in one, just to kind of keep it going. It's not just turn it on and leave it, but you have to keep nurturing it a little bit, just like anything.
Yeah. There's no. I think there's an old commercial back in the day. I think there was some rotisserie chicken solution where you just set it and forget it. And I don't think that this applies here in most businesses today. Yeah.
It's anything you implement with staff and training. If you train it once and let it go, it will drift away from where you wanted it to go, and so you have to continue with the messaging and making sure that the training remains consistent.
Great. Well, Joe, thank you once again for really sharing the insights in terms of how you've been able to address the clear financial realities of patients and how you've been able to address it, not only from a technology perspective, but really kind of from engaging your staff and making sure it drives the right, patient experience for your practice. So once again, thank you so much. And
my pleasure. Thank you for having me.
And those are the payment matters we're covering today. As a reminder, you can listen to today's episode on weekdays at 4:30 a.m., 12:30 p.m., and 8:30 p.m. Eastern. If you have a comment about today's episode or show, check out and follow #PaymentMatters or connect with me on Twitter at Jeff Lin. You can learn more about my show at healthcarenowradio.com or instamed.com. Until next time, I'm Jeff Lin.